Hi, welcome to Pathology Riddles. Today, we will be discussing about this topic called as hypertrophic cardiomyopathy. In the previous class, we had discussed about the types of cardiomyopathy and more in depth about dilated cardiomyopathy. Today, we will talk about hypertrophic cardiomyopathy because this is a very important topic. It is one of the reasons for sudden death, especially in athletes, those who are less than 35 years of age. So, what is hypertrophic cardiomyopathy? It is characterized by three components. So, what are these three components? One is myocardial hypertrophy. Hypertrophy means increase in the size of the cell. Second, it is defective diastolic filling. That is, when the heart, in between the contractions, when the blood has to fill inside the chamber, that is defective. And third is ventricular outflow obstruction. Blood that has come into the ventricle is unable to completely empty out because there is outflow obstruction. So, what is the pathogenesis? Basically, there are mutations. And what kind of mutations? They are missense mutations in one of the many genes which encode the proteins of contractile apparatus, especially the myosin, beta myosin. Now, once these mutations occur, what will happen is the myocytes will hypercontractile. It will become more contractile. And because it is continuously contracting, there is increased energy use and net negative energy balance. So since it is continuously contracting, there is not enough diastolic function. So it is not relaxing. So there is preserved systolic function, but as myocardium does not relax, there is diastolic dysfunction. So in gross, what do we see? Gross means the features which we see through our eyes. That is, the heart is thick-walled. Thick-walled, it is mainly because of the hypertrophy, increase in size of the cells. Then it is heavy, because if all the cells are going to hypertrophy, then the heart will be naturally heavy. Then we see that the myocardium, out of three layers of the heart, that is endocardium, myocardium and pericardium, the myocardial layer has hypertrophied. Then there is asymmetric septal hypertrophy. That is, the septal muscle thickens more than the ventricular free wall. So it is asymmetric. It is not thickening uniformly. It is thickening more than the ventricular free wall. And if we cut the heart, then we will see that inside the cavities, the space is reduced. So earlier, when it is not hypertrophied, we see it as round shape, but here we will be seeing it as a very narrow space, and that is similar to the configuration of banana. So the cavities will look like banana configuration. Another finding that we find is mainly there is thickening of the mitral leaflet. Because there is septal hypertrophy, this mitral, the anterior part of the mitral wall goes and hits the septal wall, and then a plaque forms on it. And when the plaque becomes thicker, what will happen is there will be ventricular outflow obstruction, and that is what we can see on gross. So under microscopy, we will see myocyte hypertrophy, and they will be haphazardly arranged. The myocyte disarray, what is normally present, won't be there. And in between the cells, in between the myocytes, that space is called interstitium. And because of the continuous hypertrophy in between, there will be interstitial fibrosis. So in clinical features, this will be most apparent during the post-pubertal growth spurt. And there will be reduced stroke volume. That is, the amount of blood that gets out of the ventricle per stroke will be reduced. This is because of impaired diastolic filling. We have discussed that the heart is mostly contracting. So there is impaired diastolic filling. There is less space as well inside the cavities because of banana configuration. And that's why we have decreased volume of blood coming out of the ventricular cavity. Then there is exertional dyspnea. Dyspnea means breathlessness on exertion with harsh systolic ejection murmur. This happens due to reduced cardiac output and increase in pulmonary venous pressure. That is secondary increase in pulmonary venous pressure. So we have angina. Angina is mainly chest pain because of myocardial ischemia, decreased blood supply to the myocardium. So this happens because due to hypertrophy, because the heart size has increased. So the blood vessel is not able to completely supply the blood to the heart. And then there is compromised intramural arteries and high left ventricular pressure as well. All these factors will contribute to angina. Next we have atrial fibrillation. If the conduction does not happen smoothly, then it can give rise to thrombus. Thrombus is basically clot, and clot can emboli and go anywhere and block the vessels. Ventricular fibrillation, that can be a cause of sudden cardiac death, and infectious endocarditis of the mitral valve, and that will lead to congestive cardiac failure. So what is the treatment? Mainly, since it is hypercontractile, we would want to relax the ventricles. So therapy which is promoting ventricular relaxation is adopted in this as treatment to reduce the or help the patient with the symptoms. Also, what is tried is partial surgical excision of the septal muscle or controlled alcohol-induced infarction of the septal muscle, because septum is too thick, right? So they are going to reduce it. So that's all for today, and we will deal with restrictive cardiomyopathy in the next class. This is Dr. Susan signing out till we meet in the next video.